Hi everyone, I'm Nina Carson, and I'm going to be presenting or sharing with you my presentation from CSM 2025 that was in Houston, Texas. And this presentation is on 90-day outcomes for veterans after total knee arthroplasty. And this work is affiliated with the University of Colorado at Anschutz Medical Campus, as well as the VA Eastern Colorado Geriatric Research Education and Clinical Center. So this work would not have been done without our co-authors at the University of Colorado, as well as our VA collaborators and clinicians at the Eastern Colorado clinics that were affiliated with this study. So thank you to them all. And this work was funded by a merit award through the United States Department of Veterans Affairs through the Rehabilitation Research and Development Service. The opinions and views in this work are solely those of the authors and do not represent those of the National Institute of Health, Department of Veteran Affairs, or the United States government. And this work was also supported by an NIH research grant funded by the National Institute of Aging. So to start, we will quickly review veteran outcomes. So we know that there is a large increase in the number of total knee arthroplasties that are ongoing in the United States. And within this increasing number of total knee arthroplasties, we have a subpopulation of veterans undergoing these surgeries. And these veterans have unique needs and characteristics, such as higher rates of comorbidities, worse health outcomes, and they're more likely to report arthritis. Veterans also have a higher burden of activities of daily living limitations, as well as higher healthcare utilization. More specifically, looking at total knee arthroplasty, veterans have worse postoperative outcomes than the general population. They have higher rates of 30-day complications, readmission, and increased length of stay compared to the general population. But we don't know how outpatient care is delivered in rehabilitation following these surgeries, and we don't know what functional outcomes look like for veterans. So this project is part of a larger project where there's 3 phases. First, we're characterizing outpatient veteran recoveries for veterans in usual care in the first 90 days. The next phase is implementing a clinical support tool into outpatient physical therapy practice. And this is using a people like me approach to create projections on how veterans might be expected to do or how they might compare to people who are more similar to them are doing, much like growth charts for pediatrics. And then the third phase of this study is to compare outcomes across those 2 cohorts to see how veterans are doing. Today, we are only going to focus on characterizing veterans during the first 90 days in that usual care or control cohort. So our purpose was to examine veteran recovery in the first 90 days after total knee arthroplasty and to look at preoperative factors associated with 90-day recovery. For enrollment, we screened 203 veterans. We had some that declined, were unable to contact, or ineligible, and we ended up consenting 89 veterans in the Eastern Colorado region. Of these, we enrolled 69, and we had 20 post-consent screen fails. These post-consent screen fails were due to surgical cancellations, loss to follow-up, and this might have been due to community care surgery or community care rehab. Of those veterans that were enrolled, we have 90-day patient-reported outcome measures from 57 of them, and visit data from 69 of them. We look a little closely at our timeline. Preoperatively, we looked at these veterans and we assessed their range of motion at the knee, so this includes flexion and extension, as well as the timed up and go, or the tug test, and the KOOS-JR. Veterans then underwent surgery at the VA or at a community care location. We then included veterans if they were seen at one of the outpatient Veterans Health Administration clinics in the Eastern Colorado area. We recorded visit frequency, cadence, as well as the timed up and go, range of motion, and the KOOS-JR from those electronic medical records. And then we took survey data from the veterans at 90 days following surgery on the KOOS-JR. Our cohort was largely male, but it was slightly less male than the general U.S. population of veterans. Our cohort was also slightly more diverse or less Caucasian than the U.S. population of veterans, and this is more reflective of our demographics in the Eastern Colorado area. For our enrolled veterans, we have 90-day surveys, as I said, on 57 of them and visit data on 69 of them. The age, BMI, and Charleston Comorbidity Index of veterans was pretty similar to the general population as well. All right, so if we look then at the knee injury and osteoarthritis outcome score for joint replacement, or the KOOS-JR that I keep referring to, this is a measure of stiffness, pain, and function in daily living. And so as a clinician, we typically look at this as a scale or a value from 0 to 28. And on those raw scores, 0 or a low score indicates high function, and a high score indicates low function. For research purposes, we then converted these raw scores to interval scores where a high score indicates high function. And we did this because the literature utilizes interval scores, and this is what the MCID, or minimal clinically important difference, for the KUS-JR is based off of. And if we then look at our outpatient rehabilitation characteristics, we can start by looking at number of visits by quartiles. And so in this cohort of veterans, there was a pretty large spread in the number of visits. It ranged from 1 to 27. And so in that first quartile, there's quite a few veterans that are having 5 or fewer visits. And so we don't know what's happening to these veterans, if they're not continuing with rehab at all, or if they're continuing in the community. And so this is an important potential way that we can target increasing rehab for these veterans. And then if we look more specifically at those veterans that are having a large number of visits in the fourth quartile, those that had greater than 21 visits all had an adverse event. And so these were 2 manipulations under anesthesia and 1 revision total knee arthroplasty outside of the VA. We didn't have any other adverse events in this cohort other than these 3. So this is potentially another area where we can intervene and try and improve outcomes for this fourth quartile of number of veterans that are having quite a few visits. If we look at time to outpatient eval, this is also a very skewed data set, with some veterans arriving fairly soon and some taking quite a long time, as you can see with that right tail. These veterans were in home health or in subacute rehab, and lots of other factors that contributed to that. So our mean time to outpatient eval was 14 days, but our median in that purple line was 8. So pretty large skew in this data set. If we look at duration of care, again, there is slightly more of a null curve, but definitely a tail to the right. We have the mean duration of care at 74 days, and the median duration of care is 64 days in that purple line. And the mean is in red. We then look at 90-day outcomes. We looked at the change in KUS-JR from preoperative to day 90. And if we look at the graph here, the change scores on the x-axis and the mean and the median are basically on top of each other here, right around 20, change of 20. If we then look at the MCID, or the minimal clinically important difference, which is about 7.2 for the KUS-JR change score at 90 days, about 20% of the veterans are not meeting this. And so this is another potential large area to intervene. And this is similar to the general population, where about 20% of people are dissatisfied at 90 days following a total knee arthroplasty. We then looked at preoperative factors associated with the KUS-JR scores at day 90. We did not find any association between Charleston Comorbidity Index, number of visits, age, sex, or BMI. Only preoperative KUS scores were associated with those 90-day KUS-JR scores. So here is our regression that we run. So on the x-axis there, you can see preoperative KUS scores in the interval format, and on the y-axis, you can see those 90-day KUS-JR scores. The beta was 0.38, and our R-squared was 0.165. So this is indicating that about 16% of the variance is potentially explained by this model. If we wanted to dissect this a little more closely, we could say, hey, a veteran is scoring 40 on the KUS-JR preoperatively. We might then estimate that they might score a 65 on the KUS-JR at day 90 following TKA, or total knee arthroplasty. So what do all these results mean? Preoperative KUS-JR scores might be helpful for anticipating postoperative care needs. Veterans with worse preoperative KUS scores might benefit from enhanced postoperative care, but largely there's going to be a lot of other factors that are influencing these 90-day outcomes on these patient-reported outcome measures, and we need to do more work to figure out what's going on with these veterans. So our next steps for this study are to continue collecting the usual care summary at the Pittsburgh VA clinics, and then we are also going to continue implementing the clinical support tool into the Denver or the Eastern Colorado clinics before additionally adding the Pittsburgh clinics to that clinical support tool cohort. And then lastly, we'll compare outcomes across those cohorts to see if this is an effective tool to implement into clinical practice. So I'd like to thank the Restore team for their work and collaboration on this project. And if you have any questions or would like to reach out to us, you can find us at movement4everyone.org, or you can scan the QR code on the slide. All right, thanks.